Good afternoon, everybody, and welcome to West Berkshire Health Scrutiny Committee. I'm Councillor Martha Vickers, Chairman of the committee, and the members of the committee present this afternoon are Councillors Nick Carter, Owen Jeffrey, Jane Langford, and we hope that Stephanie Stevenson will be joining us soon. And we also have with us today, we have Paul Coe, Executive Director of Adult Social Care and Public Health, and we have Councillor Heather Codling, Chair of Health and Wellbeing Board, Stephen Bow, our officer who is a consultant in Public Health, Matt Pearce, who is Director for Public Health, and later on, hopefully, we will have Fiona Warby, Lead Officer from Health Watch West Berkshire, and Joe England, Joint Interim Service Director, Adult Social Care. And the gentleman on the screen, is that Hugh? It's Hugh, okay. And from Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, we have Hugh O'Keefe on the screen, Head of Pharmacy and Dentistry. Welcome. Thank you for at our meeting. Thank you very much. And that's Fiona, who has just appeared. Welcome, Fiona. From South Central Ambulance, later on, that's Ambulance Service NHS Foundation Trust, we'll have Kirsten Willis-Druitt, Assistant Director of Operations, and Caroline Morris, Transformation Programme Director. Oh, somebody's just popped up on the screen. Is that Nick? Nilesh. Okay, is he doing? Okay, this is Nilesh Patel, has just appeared on our screen. Welcome, Nilesh. Vicky Phoenix is the clerk for the meeting, and the meeting is also being live streamed via YouTube, and Gordon Oliver is the Zoom host. Before we start proceedings, I'd like to explain for the benefit of members of the public who may be watching that this afternoon's meeting is being held both over Zoom and with councillors present in the council chamber. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. And please can I ask everyone participating in the meeting to make sure they switch on their microphones when invited to speak directly into them, and to switch them off when they finish speaking. If we hear the fire alarm this afternoon, we must leave the building immediately via emergency exit. The assembly point is the Dolphin Car Park, and if the lockdown alarm sounds, we will remain seated and await instructions from officers. We will adjourn the meeting until such time as it's safe to proceed. Do members have any questions about the way in which this meeting will be conducted before we proceed? Nope. Right. Vicky, do we have any apologies for the meeting?
Yes, Chairman, we've received apologies from Helen Clark, the Associate Director of Place at the Bob ICB.
Thank you very much. We'll move on to the minutes. Hopefully members have had a look at the minutes. The minutes of the meeting held on 12th of December 2024. And can I have a proposal for an approval of the minutes as a true record of the meeting? Thank you, Councillor Jeffrey. And a seconder?
So propose.
Thank you. And Councillor Stevenson has seconded. Thank you. I'll just sign the minutes. Okay. Okay. Oh, sorry. All in favour? Thank you, Councillor Jeffrey. Thank you. That's important. Right, Councillor Langford is abstaining because you weren't present. Thank you very much. Okay, Councillor Stevenson, did you vote on that? I didn't see. You did. Okay, thank you. Okay, so all voted. Thank you very much. Do we have any declarations of interest? Oh, before we have that, we have an outstanding action, item 3, on page 9 of your minutes. We have an outstanding action from the minutes about the dispute policy for all age continuing healthcare. This has been outstanding for quite a while, but now we had a report back to our last meeting. We had a follow-up from the last meeting, where we've been told that the dispute policy has been out to the local authorities for comments. It's a draft dispute policy at the moment, and these have now come back and they've been collated, and the final version will be progressed for approval this month, March, with implementation by the 1st of May. and we'll be receiving a report back on this in June, we've been told. I'd just like to ask possibly a comment from Paul and maybe Hugh as our Bob representative, whether there's any more updates on that, and can we be reassured that this will be implemented by the 1st of April, because it's been going on for quite some time and it's a very important issue to the residents of West Berkshire. Paul, do you want to comment?
Thank you, Chair. To my knowledge, I don't think this has been finally signed off and endorsed, but I do know we were very close. So I will follow up with the appropriate colleague in the ICB and just chivvy it along.
Thank you very much, Paul. Do you have any comment, Hugh? Possibly not, because I've just sort of jumped that on you. You wouldn't be prepared for that. So just be aware that we'll be following up with Bob ICB. Maybe you can feed that back to them. Thank you.
Okay. Yep, will do. Thank you, Chairman. I just wanted to be absolutely clear. We're talking about the whole situation of disputes on adult social care placements, which fall into the health service and which fall into our hands. I've got that correct, haven't I?
That is correct. That is the, yes, Paul, do you want to confirm?
Yes, the way I would express it is where there is a dispute about an eligibility decision. Yeah.
Thank you for that clarification, and thank you for the question, Councillor Jeffrey. It can be a little bit confusing when certain terminology is used, and we need to make sure people understand what's happening. I thank you for that. Welcome to. Oh, fantastic. Thank you. Welcome. Item 4, do any members have declarations of interest? No, I'm not aware of any. Item 5, petitions. Do we have any petitions, Vicky?
No petitions have been received, Chairman.
Thank you very much. So now we move on to our first item, oral health and dentistry. And I'd like to welcome partners and officers to the meeting here again. Hugh O'Keefe, Head of Pharmacy, Optometry and Dentistry, who's on screen. Nilesh Patel, a dentist and chair of the Bob Local Dental Network, who's on the screen. Stephen Bow, consultant in public health, who's here in the room, and Matt Pearce, director for public health. So could Stephen Bow and Matt provide us a short overview of their report on oral public health? Thank you.
Thank you, Chair. So this reports on oral public health and the particular responsibilities that local government have in this area. So I'll just give you a brief overview of the paper. The main oral diseases of concern from a public health perspective are decay, inflammation and oral cancer. The NHS is responsible for providing treatment. Local authorities are required to provide or commission oral health promotion programmes to improve the health of the local population. The new government manifesto included commitments to provide more urgent dental appointments, to recruit new dentists, to reform the dental contract and to introduce supervised toothbrushing for 3 to 5-year-olds. Broadly on a lot of the health indicators, West Berkshire performs better than South East and England comparators, particularly for the proportion of 5-year-old children with tooth decay. So in West Berkshire, that's just under 17% versus 21% and nearly 24% for the South East and England, respectively. But that's still, that might sound good, but that still represents about 1 in 6 children in West Berkshire with tooth decay. For oral cancer, they're around, just to get a feel of the size of the problem, there are around 20 new cases registered each year in West Berkshire, which equates to a similar rate per person to the England average. So West Berkshire Council commissions health visitors who run the Brushing for Life programme, which includes provision of advice and toothbrushing packs to the parents of infants at their 9 to 12-month development checks. The West Berkshire Family Hubs deliver a cooking and nutrition course, which includes advice on sugar, oral hygiene, and registering with a dentist. And the Health and Wellbeing in Schools team offer a Living Well Food and You workshop to all Year 3 West Berkshire Academy and maintained schools, which includes oral health advice. This year, we're also participating in the National Dental Epidemiology Programme in commissioning a dental survey of adults aged 65 years or older who are residing in a care setting in liaison with adult social care. There are a number of opportunities for further work in West Berkshire, which are outlined in the paper, including conducting an oral health needs assessment to understand the size of the problem in more detail, reviewing the implementation of NICE guidance and guidelines on oral health and oral health promotion, and development of a partnership board focused on oral health. I hope that's helpful, but happy to take any questions.
No, it's okay. I just wondered whether there was going to be a slide on the screen, but I realised you were referring to the report, so that's fine. Thank you very much.
Thank you. Councillor Jeffrey?
Thank you, Madam Chairman. If we go to page 3 of 9, or page 17, you'll see 2 dips where for West Berkshire, we went up considerably in 2014-15, and then we've again started to rise in 21-22, and that's the tooth decay among 5-year-olds. Any comments, any advice, etc., etc.?
So my interpretation of this graph, this figure 1 graph, which shows the 3 different lines, you've got the England, South East and West Berkshire trends, is that you've got a general trend in all 3 areas downwards, so a reduction in the prevalence of tooth decay among 5-year-olds, and up till about 2014-15, and then a sort of plateauing, which suggests that there's not improvement overall. The dips that you mention, I suspect around sort of small, as you get to smaller numbers, you get more fluctuation around that general trend, but that's something we can look at doing some statistics around to see if that could be the explanation. But I do think it raises the question about why we're seeing that plateauing of improvement and whether there's something we can do to continue that previous downward trend that we had been seeing before that.
If I may, to come back, my father and my brother were both mathematicians, so I've got some vague understanding when you start talking about small numbers give strange variances. Do you think that that is really the key as to why we had that big hike and now the slightly lesser one, but still it's actually on an upward trajectory? Do you think that's probably where we need to look? Is it's more to do with the smallness of the number of people or the number of youngsters that we're looking at, rather than it's something we should be very concerned about?
That would be my instinct from sort of my experience looking at these sorts of things. However, that doesn't rule out there being some sort of specific cause that happened around 2014-15, which, if we understood and could identify that, that might be something we could then address going forward. But I guess even given that sort of distance in the past, it might be of historical note rather than actionable, yeah.
Wants to make a comment here.
Yeah, I was just going to concur with Stephen. I think if you look at the English and the regional averages, you're talking about thousands of children there. So that gives you probably a better reflection in terms of statistical representativeness. I think the key thing for me is that, the graph is quite clear that for the last 15 years, we've actually seen some positive impacts in terms of tooth decay. And obviously it is worrying, as Stephen quite rightly points out, in terms of around 17, 18, we're seeing a plateau, if not a slight increase. So that's obviously something we're worried about within public health. But for me, it's the downward trend, and then that slight increase, I think, is where the key messages we need to take from that graph.
Thank you. Councillor Stevenson?
Yes, thank you, Chair. Actually, I'd like to follow on from Councillor Jeffrey's question. In the next figure, figure 2 on page 4, I'm a little concerned to see that the hospital tooth extractions for the 5 to 9 range, we are far worse than South East England and the whole of England. And I wonder if this might be a good thing that we've now introduced this scheme of supervised brushing. Did you say, what age group is that for, please, Stephen, who are going to be supervised at school?
I believe it's an early years
The
settings.
early years,
Yeah.
yes. And that's this group that are losing their teeth in hospital. Has that improved? Because that's 22 to 23.
It would be good to see what the more recent data looks like when it comes out. We're limited by the national timeframes on data production, unfortunately. So this was the most up-to-date data that we could get hold of. But as you say, you know, the numbers are notably greater in that area. So that's, you know, it is a major cause of hospital activity and the consequent sort of implications in terms of school attendance in these age groups. That's very important.
When you get the next group of figures, is there any chance you could report them back to us so that we could see what's happened?
With pleasure.
Lovely, thank you very much. And I've got a second one, if I may, Chair. Just further down, it's in under adults, just before item 3. I've highlighted here that care home managers experience difficulty with their residents. And I find that a concern because I'm not far off myself. And certainly I experienced it with my mother, that dentistry is a real problem within care homes. How are we in West Berkshire focusing upon that concern?
I'm not sure I have necessarily the best person to answer that. I don't know if any colleagues around the table might be able to speak to that.
Do we have any other comments from Matt or Paul, maybe?
Sorry, was a question around care home
It's
management?
care home and access to dentistry for care home residents.
Yeah, I mean, that probably falls under the auspices of the ICB because they commission dental services. I mean, one of the things we've referenced in here is the survey we're doing of older people. So that's going to be really important. So we don't normally get that data in terms of the level of tooth decay, but in terms of responsibility for dentistry, that fits the Integrated Care Board. I think, did we say they're online? They are. So
He's there. He's actually got his hand up.
Oh, sorry.
We're giving you a chance in a minute, Hugh, but if you want to chip in now, please do.
Thank you, Chair. Yeah, I think this is something we're looking at in terms of older people and their well-being, particularly in terms of diet and how important that is for them to stay well. We've run a sort of pilot this year with the community dental service in Oxfordshire with a couple of care homes, and we're looking to get that sort of turned into a more formal report. I think one of the things to say is that it's very complicated in terms of the number of people that are involved in looking after the oral health of older people. There's a report that came out a few years ago, Smiling Matters by the CQC, which talks about the roles that we all have to play in this. And so there's that side of it, just in terms of maintaining people's oral health in the care home, and then having sort of services that support them in terms of maintaining that health and then responding to them when they've got oral health needs. So we do have a community dental service that will go in and provide domiciliary care, but that's got limited capacity. So that's something we're going to have to look at going forwards in terms of whether we can get that to respond more quickly. But it's an issue that's multi-agency, really, in terms of trying to get this right.
Thank you very much for that. Councillor Codling has a question.
Yeah, I think it's going back to figure 1 is the data for 22, 23, 23, 24 would be really useful in this instance. And, you know, it's all very well having this data, but if it's not up to date, how can we be making any comments or decisions on things?
If I could respond, I think that's a really good point. And in this report, we've been limited to the national data that we have, but we we're getting a new public health analyst within the week, hopefully, in post, which will be very good. And one of the things I'd like to do is to work with the ICB and get access to some of that more live data, which we might not be able to present in quite the same robustness and not necessarily be able to make the comparisons to England, but we would be able to get a sense of the direction of travel in a much more timely fashion.
Yeah, I mean, there's several things we can do. So obviously we undertake or commission the survey every few years. To address, Councillor Jeffrey, your point that we could potentially increase the sample size. So we could pay more money to get more children's teeth looked at. That said, there's always a challenge in getting the dental nurses to do the survey because there's not enough dental nurses and dentists generally. So that's always a challenge with these surveys, is actually getting them to do it because they're so busy in dentists. But that's something we could consider, or the committee might want to think about in terms of increasing the sample size, but that comes at a cost to the public health budget if we chose to do that. And that could actually go down to a more granular level. So are there particular places in West Berkshire where we're seeing higher levels of tooth decay compared to other areas, rural versus urban, those kind of things? At the moment, we don't get that level of granularity. That could be something the committee might be interested going forward, but again, that would be a cost consequence.
So Carter?
Thank you. Yes, if I could just go back to the care homes, and it's probably another question for Hugh, actually, based on what you just said before. In the report on section 2, towards the end, that last paragraph, where it lists multiple factors involving primarily the elderly, although of course it's not just the elderly in care homes, but on the first point of that care home managers experience more difficulty accessing dental care for their residents than adults living in their own homes. I think my understanding is that one of the challenges is people have a care plan that includes making sure that people have cleaned their teeth, but it doesn't necessarily follow that in all cases that is enforced for whatever reason. So, for example, people with dementia or whatever will presumably need a lot of hounding to clean their teeth. And I've heard other examples of people that are perfectly aware, but they would still need quite a lot of hands-on chasing to make sure they've cleaned their teeth. And then you have the issues of perhaps people being encouraged to call it a day and go to bed and then have they clean their teeth. So I guess you must recognise that, Hugh. I just wondered if you had anything else to say as to whether that is behind one of the claims of untreated tooth decay. Presumably it is. Thank you.
Yes, I think that's right. I think there is an issue there in terms of, even if people got the care plans with the oral health in it, are those being fulfilled for the reasons you're describing, really? And I think one of the things we picked up in the pilot was that people had identified decay, and of course then you're in a situation where people consent to the treatment may not see that as a priority for themselves in terms of whether they need it. There may be capacity in terms of whether they're able to then make those decisions. And this is where things like the specialist service, like the community dental service, who are sort of kind of more expert in the area of dealing with people who don't have capacity, can provide that support as needed. But it can be that even for the residents themselves, it's not seen as a high priority. It's something they sort of rub along with, manage with. So that's part of the complexity of this, about trying to raise the profile of generally of oral health in these sorts of environments.
Lovely, thank you very much.
Thank you. Yes. Right, I can't see any members with any further hands up. I was going to, yes, Councillor Stevenson, all right.
Sorry, I've just found another highlight. It's the end of 3.1, where the final sentence says levels of access to dental services in West Berkshire for both children and adults are significantly lower than England. And then we've got a few statistics above. That's of some concern, surely.
This is a point that's really important, but I haven't been able to get to the bottom of the interpretation of that, and it's something that we'll be looking into because this is sort of a metric around service activity. So it could be that the level of need is lower in West Berkshire, which could lead to lower service activity, or it could be that there are an indication that people who do need access aren't getting it. So it's impossible with just the data we've got here to distinguish between those two possibilities. So we'd need to look at that in a bit more detail or get some insight from some soft intelligence around that from local people or services.
Thank you. Chair, can we follow that up then, please?
Very much so. Yes, I was going to ask about that. Yes, some of the statistics are a bit confusing. One minute we're sort of doing really well, and then there's comments like that. So there obviously, I think there's quite a lot of things coming up here where we're going to need to hear a bit more in the future. I was going to ask about, I mean, obviously public health, we're all about prevention, public health, aren't we? So we're going right back to early years and to what parents can do. And there is information here or comments about health visitor-led services to help parents, promoting regular brushing. Do we have use of the hubs as well, the family hubs? There's a mention of the 9-month check, I think. This information is meant to be given by the health visitors. But do we know how many children are accessing, parents are accessing these checkups with their children? And surely it's going to be the most needy groups that are going to possibly not turn up for that check. Are they followed up? You know, so it's how we focus on them, and do we have the information about the take up of these checks? And the family hub has it got the capacity? And a lot of the services they have, they charge for. So how many families? And again, it tends to be the more well-informed that access the family hub. So again, you've got a whole cohort that are missing out here, possibly. I don't know whether you can identify them as those on preschool meals. Councillor Codlin wants to comment. Do you want to comment before Steve or whatever?
Do you mind if I did?
Go ahead,
Just on the family hub side of things, it is an area that actually government are putting in some, we're waiting on some new legislation this year, and we're getting a new budget in April for how we fund those family hubs and looking after children generally from 0 to 19. And we are going to be looking at expanding services across that. So I would imagine dentistry would be on that list. It's an important area, and it's one of those things that wouldn't necessarily be charged for. It's one of those things that we should be offering out as part of our outreach programme as well. So I think that is something that we would be looking at, but I will certainly talk to Anne-Marie about it.
That's good news. Thank you. Steve, did you want to comment?
So just in terms of the health visiting 9 to 12 month checks. So just to give you a flavour from the most recent data we have in Q3, 369 children were due a check in Q3, and all were offered a check. So 100% were offered a check. 92.4% took up the offer and were seen at that check. 51 were classed as targeted, and 50 of them took up the offer and were seen by the health visiting service. So if that's helpful to get a flavour of the, they're above the targets that we have for the service, but we are looking at starting to gear up for the recommissioning of the contract in 2027. So we will be able to look at how we deliver that in future too.
It's useful that we've got that information. There's also these special groups, the special needs groups. There's homeless people are mentioned here. You've mentioned those with reduced capacity, sex workers, etc. I don't know whether we have any figures about those or any special plans about how we can assist them. And I mean, the homeless tend to miss out in lots of ways, obviously, for obvious reasons. I think we were trying to get a little bit more information about our homeless cohort. and whether any initiatives there, but we haven't got that so far. So that might be something that also that we need to follow up on. But I don't know about the sex workers. Is that something that we have an issue with? Obviously, there's the health issues as well, smoking, alcohol, etc. But there's specific cohorts of people that obviously we need to support.
I'm not aware of any specific activity around oral health in sex workers, but colleagues could correct me. On homelessness, Councillor Codling will be aware that in the health and wellbeing delivery plan, there's, this has been one of the actions there, but there's been sort of a consistent struggle with improving access to dental treatment in that client group for recent years. So it's an outstanding action that is still on the action plan for the homelessness strategy group that takes responsibility for that. Okay,
so that's something we might possibly hear more about in future, maybe just see what's happening. All right. I was also going to ask about fluoride, which is mentioned in several places, about how's the debate about fluoride? We mentioned fluoride varnishing, which I don't really know very much about, and what's the access to that? And is there still a debate going on about whether we put fluoride in water, or is that sort of been and gone? Is that not very popular?
So there has been, you'll be aware of the work in the north of England around fluoridation of water supplies. I don't know if, Matt, you've got any further insights or comments on fluoridation of water?
So there's 2 points. I think the fluoridation in the northeast of England says a national consultation underway at the moment, and that's engaging with the public about whether they want to see fluoride added to the water. So I think all eyes are on the northeast to see what the outcome of that consultation is. I think there's always two sides of an argument in terms of fluoridation. Are we doing to people, or but we know the evidence is really strong in terms of areas that have fluoride in their water. They have less tooth decay, and the evidence is really robust on that. I know some health and wellbeing boards have actually written to the minister to say, actually, we want our area to come next to be, put up the pecking order, if you like, in terms of putting their area forward for fluoridation. So some areas have written to the minister to request that, but we're all waiting for the northeast. In terms of fluoride varnishing on children's teeth, I don't know what the level of extent of that is in West Berkshire. I know in some areas it's more common than others. It might be, I think what I'm getting a sense of from this report is we need to do a bit of a deep dive in the data. All the questions that's coming out of this committee. Stephen's already mentioned that we do a health needs assessment. So what we've given here is a bit of a summary. A big comprehensive health needs assessment would be a lot more than that. It's understanding some of the questions you're asking the public what their views are. And that would give us kind of a richness in terms of what are the things we need to do. Do we need an oral health strategy to help address some of those issues? So I think the fluoride varnishing is something we know, again, can be really beneficial for children. If we paint varnish on their teeth, that will potentially prevent future tooth decay. But again, I don't know how common that is in terms of the dentists in West Berkshire, whether they do that or not.
And that's not something you necessarily have to pay for. That's something from the NHS.
No. Well, as long as you've got access to an
NHS dentist.
Yeah.
Right. I mean, the last paragraph, virtually, I don't know whether this has been raised by members already. Levels of access to dental services in West Berkshire for children and adults are significantly lower than England. I mean, I think, did you raise that, Councillor Stevenson? You did. So, I mean, that's a major issue. And obviously it overlaps with, we're going to be hearing from Hugh in a minute. And I think probably this is a conversation that we have with health, isn't it, about what we can do together. Did you?
One of the things that occurs to me from many of the meetings we have in this room about underprivileged children is that, and it was said by the Health Secretary of State on the television just the other day, why are schools having to do this brushing thing when really it should be a parent thing? And it was in my young day, hundreds of years ago, a parent thing. It seems to me there's an overlapping issue about parenting in this country, which is falling down in some way, shape or form, and thereby putting pressure on schools in terms of dentistry, but in all sorts of other areas as well. So I wonder if Health England has an overriding issue between all the various parts of itself, dentistry being one, where they are looking at how to try and improve parenting.
I think this is something that Matt's particularly keen on, so I'm sure he'll want to comment.
I'm happy. I mean, it's a difficult one, and I think it's that personal responsibility versus state responsibility, isn't it? And we have this dilemma in public health all the time. Childhood obesity is another one, where people talk about parental responsibility, the home environment. I guess what we also recognise is we live in an environment that really drives sugary food and sugary drinks. If you walk down the high streets, you will be bombarded with advertising. It's easily accessible. And that's really hard as a parent, and as a parent myself, even I find that difficult, fending my children away from those kind of sweet foods and drinks. So it's a fair argument, and I know that's been fielded to the minister. You're right in terms of, why are we doing supervised toothbrushing when actually if children brush their teeth regularly at home, we wouldn't need it. I think the sad reality is that some children from the poorer communities and households have higher prevalence of tooth decay. So for me, it's a whole system approach. I think it's a combination of things. Parental education, it's about how we reduce access to sugary foods. We've got the sugary tax already in existence across the country. So I think it's a multi-layer different intervention that we need to do, but certainly, supporting parents in how to raise children, absolutely, that's something we want to do. And that's probably what health visitors do. When they're raising children, they give them tips, advice, and help them how they parent their children.
Can I yes, thank you. You've touched on what I was really trying to ask, is there an overriding look at how we can help parents? I'm not saying we shouldn't do it in schools and all of those other places and advertising, but at the end of the day, helping parents to be better parents is obviously one of the things we can do. And you've just said to me, I think, correct me if I'm wrong, that health visiting is the only way we manage to help parents do better parenting. And yet we know that health visitors are becoming fewer and fewer.
Yeah.
So what's the answer, please?
Yeah, no, and apologies if I said the only. I don't think it's the only. I think there's some great voluntary and community sector organisations, Home Start, and people like that out there as well. So I think there's lots of agencies that support parents. I think we can do more, actually. One of the things I'm putting together at the moment is my Director of Public Health annual report, and it's on the best start in life. And the Councillor Codling talked about Family Hub. So it's parenting support programmes, what provision is out there online. There's a fantastic evidence-based programme called the Solihull Parenting Approach. It's about how the brain grows, how we meet children's needs, nurture, and things like that. So you're absolutely right. And it's probably a generic thing, not just oral health, it's about food, nutrition, breastfeeding, weaning, all those kind of things wrapped up and making sure that people have that support.
That's an important issue. Thank you for raising it. We are talking about parenting support in our task group, our mental health task group. It's quite a big issue. And there's actually, if you can access those, anybody have access, there's some really useful information about the variety of parenting support groups that there are. So there's lots to, which I think it was in Matt's report, there's lots to sort of choose from when we're looking at how to support parents.
Can I, forgive me, just a comment on that, really. It is good that there's a variety of help available, but that very variety can be very confusing. And you can get people who are in the know will access all these variety of things. People who are not in the know are still not in the know. And it's how we get to them. And that's where the health visitor used to come in.
Thank you. Councillor Codling.
Yeah, just to say that, a number of years ago, we had more family hubs and Sure Start centres, which actually helped educate the parents. And that's the bit that's missing. We're not actually teaching parents how to parent because you don't know how to bring up a child. It's not something that you just do. And if you don't perhaps have your family around locally, you don't have that support network. So that's important. So hopefully that is what the family hubs and the changes that are coming through will help with. And I've just had an email back from Dave Raitt, And he said that the initiative is going to be focused on early years providers, so nurseries and primary schools, with an emphasis on deprived areas. So at the moment, the family hubs won't be looking at doing, you know, the dentistry type knowledge, but that's something hopefully we'll do later on. Okay.
Yes.
Can I just come back, just with the supervised toothbrushing, my sense is there's unlikely to be any funding come to West Berkshire for that. I think that's primarily targeting the more deprived communities in England. That would be my sense. I've not heard anything. So I think that's not to say we can actually develop and implement something ourselves locally, but that would be my sense. I'll have to wait to see the detail in terms of which areas the government's going to be focusing on.
So it's important that we identify deprived communities because we know we've got some deprived communities. So what you were going to say, Councillor Stevenson?
Just the very same thing that I hate it when West Berkshire's, you know, suddenly we're all wealthy and all our residents are wealthy when we know very well there are pockets of deprivation that are very low on the scale.
So it's really hard because we don't get the funding because of this generic assumption that we are all wealthy. But so we have to think of ways we can help those smaller communities. Right, thank you for your discussion. I'm aware that we've got Hugh who's got to contribute, but from what we've said, I mean, we're obviously going to need to come back to this. So do you think the main issues that we want more feedback will be on what's happening with the elderly in care homes? Would that be one of them? And also obviously with the preventative services with children, well, there's a reference to a whole school approach here, whether or not, how many schools you've got that for, is that working? And are we able to target our more needy communities? And also the special groups such as the homeless, you know, have we got more statistics about them? And there were some of the stats, I think, obviously you've taken sort of a note of those. And we'll hear more about the hubs and how they're supporting. Was there anything else in particular that you think? Obviously, Vicky's got notes, so I'm sure she'll know what we need to follow up on. Okay, right, thank you very much for that. And thank you to our officers for their contributions. Right, well, we now have Hugh O'Keefe from the Bob ICB, who's going to provide an overview of his report, which you have in your pack, on NHS dental services in West Berkshire, followed by Nilesh Patel from the local dental network. Thank you, Hugh.
Thank you, Chair. Yeah, it's probably between Nilesh and myself. So I'm the commissioning lead for the ICB, and Nilesh is a clinical lead for us. So we'll provide that expertise in terms of this discussion. The report you've received is an update in terms of recovery of dental services from the pandemic. We're doing sort of 3 of these meetings over a couple of weeks. So we're updating other health and overview scrutiny committees as well in terms of where we've got to. In terms of some of the key headlines that we've got in the report, dental access is improving. This is in terms of the numbers of unique patients attending. We're still below the levels that we were achieving pre-pandemic. And there are challenges for particular patient groups, and that's particularly those who've not attended a dental practice in recent times. Patients are not registered with dentists, so that's one of the things to take into account with this. So that is an ongoing challenge for those. We are commissioning and delivering more activity, which means that capacity is expanding. But at the same time, since 2021, we've had 19 practices decide to leave the NHS and 11 have reduced the NHS commitment. That's 6% of our capacity has been lost in that period of time. None of them are in West Berkshire in terms of making those decisions. And where we have lost activity, we have recovered about half of it now with local practices. So they've taken on more activity. That includes some extra provision in West Berkshire, 5,000 more units of dental activities, it's known, are being commissioned in the patch. And the other half that we've lost, we're re-procuring. We're bringing in new practices to cover areas where we've had more substantial loss of activity, and that is Oxfordshire. So the loss of NHS capacity in Oxfordshire area is more like 11%, and certain local authorities, it's even higher in terms of the extent of loss they've had of NHS provision since 2021. That extra activity, those new practices are due to go live later in the year. In terms of national and local actions then to support recovery, the minimum price that's paid per unit of activity for the dentist has been increased. The dentists all have variable unit prices they get paid to them based on a reference year that's now 20 years ago. And so that price was increased to £23 in 2022 and has gone to £28 per unit this year. 50 practices in our ICB benefited from that increase to £28. There's been a scheme that's known as the Golden Hellos to try and encourage recruitment in those areas where it's been harder to recruit dentists. So we've implemented that. And we can now pay for higher levels of performance with the dental practices. So they've got cash limited contracts within which they have to deliver their activity targets. And up until recently, we could only pay up to 2% over that target. We can now go up to 10% over that target. So we can pay more in relation to the delivery each year, which then helps expand the capacity there. We've talked quite a bit in this meeting already about patient groups, maybe some of the more vulnerable patient groups who are struggling to access dental services. So we're running something called a flexible commissioning scheme where practices can convert a proportion of their activity from hitting activity targets to providing sessions for these patients where they can spend more time helping these patients to get dentally fit. The idea is to bring them into continuing care, not just to deal with urgent care. So that includes patient groups who've not been to the dentist for a period of time, relocated to the area, asylum seekers, looked after children, families of armed forces personnel. This year we've added patients in hospital treatment and pregnant and nursing mothers. And going into next year, we're going to add residents of care homes who can get into dental practices. So there's these patient categories that can be seen by these practices. It's about 25,000 patients have been seen under this scheme since it started. We're about to go into year 3. There's 34 practices involved. It's an opt-in system in terms of how they take part. There's 1 in West Berkshire involved and 2 have applied to join the scheme from April 25. So likely to go up to 3 from April. Talked a little bit in the earlier report about the additional urgent appointments, the manifesto commitment for additional 700,000 urgent appointments. So we started that in January as a pilot initially, and that's going to be rolled out in 25-26, and all ICBs have got targets in terms of the amount of activity they've got to deliver. So we've got to deliver an extra 15,500 urgent appointments. In terms of oral health improvement, the new practices in Oxfordshire will have a proportion of their contract flexed to focus on children's oral health improvement. And we'll be looking there for different types of roles in terms of people working in the practices and then working with local authorities in terms of trying to get this model established. It's also worth saying that there are plans for new dental contracts from 2026, and there's a bit of focus in those on oral health improvement, and particularly for children. So that's then joining up a little bit, I think we're seeing with the supervised toothbrushing scheme. So we've not heard too much detail about that yet, but we think this time next year there's certainly new substantial changes to the contract, if not a new contract. And the other thing just to flag is challenges around waiting times for referral services. So they remain challenging, particularly community-based specialist oral surgery services, which divert patients away from hospital, and community dental services, where we've talked a little bit about particularly the children's services area. So we invest where we can to try and help those services recover, but that does remain a challenge for us. And that's the report. Thank you.
Thank you. Does Nilesh Patel, do you wish to make any comments here? No? No, he's shaking his head. Okay. You mentioned community dental services. I mean, they used to be quite prominent, and I can remember they were really, really good. You had very extremely caring. I mean, not all dentists are caring, but the dentists at the hospital tended to be ones that could cope with people who maybe sometimes even had a phobia of dentistry or particularly nervous. You know, people with special needs and children who were anxious. I mean, I'm not even aware that we even have that facility anymore. When you talk about community dental services, have we got a community dentist at the local hospital at, say, West Berkshire? And where would one need to go to access this dental service if it's still available? And is it there for people who have special needs? Is that what it's there for?
Yes. So it's the Berkshire Healthcare Foundation Trust is the provider. So they do provide, as you described, really, it's a service for patients with special needs, particularly learning disabilities. The main cohort of patients they see is children. They will treat patients who have some of the anxiety and the phobias you described, as long as they meet their criteria for access. In Reading, there's a sedation service for people who find it difficult to get to a dentist but don't have other special needs. So there is a service there. And the community dental service does have a presence at the West Berkshire Community Hospital. So they've got a clinic there that's provided a few days a week.
Thank you. That's good to know. Councillor Jeffrey.
Thank you, Madam Chairman. Couple of comments. If we go to page 31, you see the table at the top there. What I'm going to say, I don't want to get over hung up on it, but it's almost just a little bit of irony that in West Berkshire we've got 19 practices, Woking will have 14. We managed to do a little bit more in terms of UDAs commissioned, but if I've understood it correctly, UDAs delivered were higher in Woking than they were in West Berkshire. If that's a useful comment to follow up on, but if it is just within the realms of statistical error, then don't worry about it and just say that. But if you then go down to the final paragraph, where there is a reduction in practice activity targets to support access for more vulnerable patients. I've read it and I've not understood it. Could you please explain it to simple old me what that final paragraph actually means?
Yes, yeah, I can do. Can I just, because I'm looking at the table, I can see the table you're referring to with those numbers. Is it the paragraph below it that you're referring to?
It's the end paragraph on page 31, which starts in a reduction in the number of practices.
Yes. Yes. Okay. Yes. So, yes. So the question on the levels of activity commissioned and delivered that you're raising, yes, the levels delivered are a bit lower in West Berkshire than they are in other parts of Berkshire West. Not substantially on the whole, we're sort of seeing good recovery in terms of those levels delivered. But yeah, they are a little bit lower. So what happens with the, so in terms of the paragraph below, when the practices join the flexible commissioning scheme, we retain the level of funding they have, but we reduce the target they have to hit in terms of the number of UDAs, because some of that activity is replaced by sessions to see these more vulnerable patient groups. So we then buy sessions from them for these patient groups. That's what that means in terms of there is an impact then in terms of the flexible commissioning on the overall levels that we commission. And what I'm saying is, despite us doing that, we're still commissioning more than last year because we've managed to have some good uptake from the local practices to do more NHS work.
Stevenson?
Yes, thank you, Chair. I just want to give a personal anecdote that I think I became a private patient at some point in history. I don't think I was asked. I just moved across and have been ever since. And in fact, the chair and her husband are the same. So we three, at least in this room, and there's probably more of us, aren't anywhere in any of these statistics. So there's a whole group of people who aren't reflected in the statistics because they're paying for private dental care. So do I take it you don't have any statistics for that sector? I'm not arguing and saying I shouldn't be paying, but do you know?
So I just missed the end of your question. Sorry.
Do you have any statistics at all about the patients who aren't being treated within the NHS system?
In terms of the numbers going through the private system, we don't. No, we don't. I think nationally there is some data about numbers seen, but we can only see the NHS picture in terms of what's happening. I think there was a useful bit in the report we just looked at earlier in terms of the numbers that don't go at all. And that's one of the things that, and I recognise that, I think it was around about the 20%, and that's a figure we sort of recognise, that there's about 20% of people for lots of reasons don't go to the dentist at all, tend to only go when they have issues. There's often quite a strong socioeconomic link with that. I think that's part of the thinking that we've got with the government now about the additional urgent appointments to try and make sure there's that capacity for people to get as they feel they need to. But the information that we have locally on private provision is we don't have it really, no.
Sorry, may I just follow up? I have a friend who moved away from our area 20 years ago. He returns every 6 months to his dentist because it's NHS.
Right.
Because in the Midlands,
Okay.
couldn't find
Okay.
NHS dentist. And that's interesting too, because you're not really allocated to a dentist, are you? Not as we are with
No, you're not, no.
floating dentistry.
Yeah, you can go where you want for dentistry, yeah. Yeah.
Thank you, Councillor Stevenson. Well, access is the big issue, isn't it, really? I mean, it's quite a large see that, I mean, obviously it dipped during COVID for obvious reasons. But to see that it's still just below 50% access to dentistry, I mean, it's pretty alarming. So those figures will encompass all of the population? They're not just those who access NHS services, or is that the population as a whole?
That is a percentage of the resident population of the ICB.
Okay, so that's everybody. So that's pretty a lot. And we are aware, I think Councillor Stevenson and I attend the Joint Health Overview and Scrutiny Committee. I think that's what it's called. And we did get a report on dentistry, I think, the last time we attended. And we heard about, I think it's what you're referring to here, this flexible commissioning.
Yes.
Which is meant to be targeting areas that have a more vulnerable population, a higher degree of deprivation, is what we understood. And we did ask, I don't know that I ever got a proper answer, about even though West Berkshire is considered to be relatively affluent, was there any possibility of us getting some funding for our more needy population, you know, to get a little bit of extra funding so that we can help those that aren't accessing you know, and is that possible, or have you got to be sort of needy as a whole, a large population?
So there tends to be quite a strong link between sort of activity levels that are commissioned being higher and levels delivered being higher in more deprived areas. It tends to be more NHS provision. So if you go to certain postcodes in Reading, for instance, the levels of NHS provision are very high. And there's an element to which this is market driven in terms of whether the dentists will see a sort of private NHS mix in terms of how they operate. So the flexible commissioning scheme we've got is really it's an opt-in arrangement for practices who feel this would work for them as a practice in terms of then saying, in terms of their contract, having that flexibility helps them. And one of our reasons for introducing this scheme, alongside supporting people to get into dental care, was to support those NHS practices to stay in the NHS, not to find that they were, having problems which meant that they couldn't stay. The issue about recovery, one of the challenges we've faced is because patients haven't attended a dental practice for a period of time over the pandemic, when they've then gone, they've got increased treatment needs. They need more treatment time. That takes longer for the dentist to complete. The dentist is then just paid the unit of dental activity for that treatment. So that actually creates contractual risk to the dentist if they take those patients on. And that's one of the things we wanted to try to alleviate for those practices through this scheme. The contractual risk for many of the practices in the more deprived areas actually is lower, in that the patients just keep coming through with the need, and those dentist practices can get through those patients. So it's really trying to set up a set of arrangements that can support the patients and the practices. Now we're adding in the additional urgent appointments as well, and we've got a few of the practices, in the sort of west of Berkshire involved in that, and I think we'll have that going into next year as well. So it's trying to get this sort of mix of your normal core contracts, flexible commissioning, paying for higher levels of performance if people can get through that activity, and the urgent dental appointments. And the elephant in the room, really, with all of this is workforce. So in some parts of our patch, it is proving harder for the dentists to recruit than in others. And that tends to be, as we get into the more further out of London, more rural areas, there is more of a challenge for the practices in terms of recruitment.
It's interesting. It's all very complicated, isn't it, really? Because
yeah, I've made it sound it probably.
what you're saying, but I mean, because I was told that there's plenty of dentists, that it's not an issue of not enough dentists in the country, which when you hear about not enough service delivery, you think of the personnel, but it's just that this argument about the pay and the responsibility and all that needs to be sorted.
Yeah.
Yes, I wonder if I can add to Councillor Stevens' comment and tell you a little story. I'll be as brief as possible. About 5 or 6 years ago, I was needed to go to my dentist's hygienist, and I was asked to pay it in advance of the appointment. I think it was to the tune of £50, which I did. On my way to that appointment, I was phoned to say that the hygienist couldn't get to it was stuck in traffic or some such thing. So could I go home? Which I did, expecting the dentist to then phone me to rearrange the appointment. Nothing happened, so I then phoned the dentist for the appointment, and they said, "Oh yes, but you have to pay in advance." I said, "Well, I've already paid." "Ah, but have you got the receipt?" And they only give you a tiny little receipt, till receipt, which I hadn't got. So I forewent that hygienist appointment, and then found another dentist, and the same thing happened to me again. This is an NHS dentist. I now only go privately, but not to either of those two dentists. I therefore have a very poor opinion of dentists, I'm sorry to say.
So yeah, that doesn't sound great. And anything like that, you can refer that to us, and we can look into it. So we can follow that up. This issue of paying before does happen, and I suppose it is worth people being aware that the dentists are collecting the money on behalf of the Exchequer in terms of when people go to the dentist and pay their fee. There can be problems for them in terms of sometimes people paying after events. So that does happen a bit, where they'll ask people to pay up front, because that money is then subtracted. It's assumed that money is collected is subtracted from what they get paid. So there's a sort of incentive in the system to do that. I'm just interested in the fee you paid. I'm just wondering if that was an NHS fee, if that's £50. Doesn't sound like a familiar fee to me on the NHS, but that can be an issue of confusion at times, whether someone's offering, even if they're going on the NHS, are they being offered an NHS appointment? So anything like hygienist treatment, the key question there is if it's clinically necessary, it should be on the NHS.
Well, I think, according to Councillor Stevens, I think a lot of us are being pushed onto paying privately by stealth.
Okay.
Thank you. Gosh, it's a big issue, but obviously I'm assuming you work closely with our public health colleagues here, don't you? Because obviously prevention is important here. You think you're working closely together, or do you think that could be improved, or because the access and the urgent access is important, and establishing a good relationship with the dental service, I mean, that's part of the whole thing, isn't it? So you're preventing terrible decay from happening, because tooth decay is a terrible thing in toothache, and you need to sort of prevent this as much as possible. So do you think we're working closely enough here, and maybe identifying why people aren't accessing dentistry? Is it just cost, or is it access? There's still a lot of work to be done, isn't there?
Is that to me? Is that the question to me? Yeah, I mean, I agree with all that, and the interesting discussion earlier was about children and access, and a lot of the work we've been doing in the last few years has really been about recovery from the pandemic. We feel, touch wood, that we're getting through the worst of that now in terms of trying to get out of it. But before the pandemic, there was a national programme called Starting Well that people might be aware of, Dental Checks by One. And what that was trying to do was build the habit of dental attendance very early in life, so that people are not, for many children, they may first only attend when they have a problem, they've got pain. So, and this was focused in more deprived wards. So we used to be, Slough used to be part of our patch, so we were one of the national pilots in that. And what we're trying to do now with the work we're doing around the new practices coming to Oxfordshire, and we're just being opportunistic because they're coming in. We can adapt their contracts as they come in, is to look at something along those lines again. And then it's to start to think about, where, as we do flexible commissioning, if we do get a slightly more stable environment with access, can we do more around that oral health promotion? Because for us, I think the key thing is this early habit of going, and not first going when you have a problem.
Yes, very important. Matt Pearce would like to comment.
Yeah, I mean, in direct response to your question, I think partnership working can be better. One thing we don't have in West Berkshire is a oral health improvement board. So, again, I don't want to create boards for the sake of it, because everything is a priority, and we have lots of subgroups and boards as it is under our health and wellbeing board. But as I'm a director of public health for Reading, we're having exactly the same conversation, and we are setting up an oral health improvement board. So there is something about, is there a role for a Berkshire West Improvement Board, or whatever footprint it sits at? It brings all the relevant people together to actually come up with a comprehensive plan around oral health. And we've got the NHS 10-year plan coming out in June, summer, and they're all talking about prevention. So I think there's more that can be done, I think, because it's not a single organisation that can actually support oral health. It needs us all coming together. So it's just how we find the right forum to be able to do that, I think.
Thank you for that. I mean, that's so lots going on and lots of possible changes and improvements. So I'm sure we'll be hearing more. Maybe we have another report in 6 months' time or something, just to see what's being progressed, and hopefully the stats are better, or we hear whether the Oral Health Improvement Board has been set up and whether liaison has improved. Do members have any comments about specific things they want following up, or we just like to? Councillor Langford.
Yes, I wonder if we should, I don't want to put undue pressure, but I wonder if we should be looking at people who actually leave the NHS and go privately, and why? Because I think there is a stealth organisation going on, and I haven't yet met a poor dentist.
Haven't yet met a poor dentist. Well, that's good to know. Oh, you mean poor as in monetary poor? Oh, I thought you meant performance for a minute there. Okay, Councillor Langford. Well, that sounds like a difficult one. I'm not quite sure whether that's possible to do that. I don't know.
Is that a question about patients or dentists?
I think it was about, I think Councillor Langford was just basically saying that people are being pushed into going private by stealth, I think was the term she used. And she wondered if it was possible to find out why people leave the NHS to go privately. I don't know. She thinks maybe there's too much of pressure on people to go private. Should we let Hugh?
Yeah, I don't know. I don't know if Nilesh has got a view on that one in terms of, I mean, there's certainly views from the dentists themselves, I think, about, you know, the way the NHS contract works. And I think it's one of the reasons we've been seeing a lot of action nationally being taken on that over the last couple of years, because I think those concerns, as I think I was saying, the contract we have now is based on a reference year from 2004-05. So it's due for review. And there was sort of pilots and prototypes run with the contract for about 12 years and were wound up. And now they're doing this work that we've seen over the last couple of years, which is in both these papers today and next week. And some dentists are, deciding that they don't see a future in the NHS for themselves and leave. And also it can be a challenge for the dentist to find, even if they themselves are committed to an NHS practice, to find dentists to come in and work for them who want to either work on the NHS at all or have a substantial commitment to the NHS. So there's more younger dentists now coming out and going straight into private practice. So it may be some of those patients then are caught in that situation where the practice is trying to navigate their way through staying in the NHS, hitting their targets they have to hit, having a viable business, and also trying to run that alongside a private practice and potentially making a choice to move one way or another. I mean, just as a general point, not all NHS practices see all categories of patients. So some, anyway, will only see children on the NHS. And that's something that's been in place since the contract came in 2006.
So there is a lot of work to do with the NHS to make it more attractive for dentists to stay within the NHS. I mean, that is the major thing.
Yeah.
They are businesses, so they have got to be recompensed.
I just wanted to say that this isn't a new thing. My daughter's in her early 30s, and when I went to register with my dentist, and I was an NHS patient at the time, they would only take my children if I went private. And that was the only way I could get a dentist for my children. And that's 30 years ago. So it's not a new thing.
Yeah.
Okay, well, this new contract came in a while ago, I think. So maybe it's all down to that. Right, Councillor Carter.
Yeah, it seems as if the stats are October 24, 33% of practices were accepting new NHS adult patients, significant decline since 2022. And in fact, in the southwest of England, apparently 98% of NHS practices were not accepting new adult patients as of 2022. So I didn't think it was old news, really, and it's just dropped off year on year. That's ChatGPT, by the way.
I think our current figure we've got 189 practices. There's about 75 are accepting new NHS patients, whatever that is, as a statistic, and something like 60 are not accepting, and then some are not declaring on NHS Service Finder. So we track that quarterly in terms of numbers of accepting. But some of the practices may not be identifying themselves on NHS Service Finder as accepting, but they might be doing flexible commissioning, so they might be getting patients in that way as well. There's been a sort of nervous, people might remember the BBC survey from about 2021, I think, was 1% of dental practices nationally were accepting new patients. So it's a significantly improved situation since then. There has been a sort of nervousness in the dental community about publicising the fact that they're open to see new patients, and then a concern of being inundated with requests to be seen if others aren't seeing them. So there is a sort of balancing act there in terms of their perspective on that.
Well, thank you very much, and thank you for your report. We look forward to hearing more, maybe in about 6 months' time, Councillor Langford.
I'll be quick. I think what's happening, I've observed this happening, is that new practices advertise for new NHS patients and then by stealth move them to being private patients, give up the NHS work after a while and stick to the private practices. I think the whole thing needs quite a tightening up and an understanding of the contracts. Sorry to take up your time, Chairman.
No, that's okay. Thank you very much. All these comments are important. Nilesh, you'd like to comment? I thought you might, because you are actually a dentist, aren't you? Yes, carry on.
Yeah, hi, can you hear me?
Can you hear me?
Yes. Yes, I thought it was probably useful to give some context to some of the comments that we made and give the other side of the story. So I'm a practicing dentist. I do dentistry. I've been doing dentistry today. You can see in my background, I'm in clinic. I'm seeing NHS patients all day, and I'll be seeing patients after we finish with this. The context is some of the fees that are available to the NHS, and I think that's always probably quite helpful. You spoke about the minimum value of the point system that we work under. And so the minimum value that's commissioned is £28. And so to put that into context, what that means, if a new patient rings our practice up and has toothache, we book them in, we find a slot, we bring them into the practice, we find out what their problem is, we find out what the dental history is, we find out what the medical history is. We examine the patient, we might take x-rays, and if the decay is sufficiently deep, they might need a tooth taken out. And so we might do all of that. And the fee we would receive as an NHS practice, not as a dentist, if we work on the minimum terms, is £34. And so I run a practice. And so for that £34, I'm meant to pay the dentist, pay the nurse, pay the receptionist, and pay all the infrastructure. And so I don't think it's too hard to understand how difficult that can be. And despite that, some of us are still desperately trying to cling on to the NHS and provide NHS care for patients. But the system is really working against us. Every year, we should get an uplift in fees to reflect inflation. And so last year, we got 10 months late, we got an uplift for expenses of 1.6%. And so I'm sure you'll all know, looking at your own shopping baskets, your own utility bills, inflation isn't running at 1.6%, but that is what we got paid extra to see our patients. So it's becoming progressively harder and harder to keep the doors open to NHS patients and NHS practices. And although my practice is majority NHS, I've, in the 17 years I've been here, we do 7 times as much NHS work as was done by my predecessors. It's harder and harder to keep that up because the fees just don't help. It is almost impossible to work on a practice that is purely NHS because on those fees, you can't pay the heating, you can't pay the rent, you can't pay for the staff. Minimum wage has gone up by 6.7% from April. National insurance changes are coming to affect us, whereas some other parts of the health system are being compensated for that, we're not. So I don't want to make out as if dentists have a really hard time, but working in the NHS system can be really hard, and you can see surely from the figures that I've mentioned why people are moving away, and some really don't. You know, people have been NHS dentists for 20, 30, 40 years. They've got great loyalty to the patients. You know, I've seen generations of families. I still see them. I see kids who are now parents. I do not want to deny them care, and we don't deny them care, but it is getting hard. It's getting harder and harder to keep doing it. And so I think that's probably useful to say. That was an example of a patient in pain. If a patient comes in who needs, for example, 7, 8 fillings and they're still there, whether they're adult or child, the practice will get paid £140. Now that might take, if they're working the minimum figure, and that might take 5, 6 hours of work, of which you're going to pay all those costs that I just spoke about. And it doesn't pay, it doesn't, it's not even about it being rewarding, it doesn't even pay the bills. And so that is why you're getting the push away from the NHS. The hygienist comment that was mentioned earlier, it probably was private, and that's because practices just need to subsidise the NHS fees with some private income just to make it work.
Well, thank you very much. That was useful to hear that. I'm glad you contributed, because I was hoping to hear a little bit from your experience on the ground. I mean, it's all about a conversation, isn't it, between compromisers, and you are a business, so there's a lot of conversations that need to go on through yourselves, NHS, and through public health. So let's hope the conversations keep going, and we'll hear a bit more, hopefully, maybe in about 6 months' time. So thank you, everybody, for that contribution. And now we have, waiting patiently in the corner, we have Caroline Morris, Transformation Programme Director for South Central Ambulance. So we don't have Kirsten. Oh, she's on there. Oh, hello. And we also have Kirsten Willis-Druitt on the screen, Assistant Director of Operation. I'm sorry you've had to wait, run a little bit over time, but it's really great to see you and to have yourself in person, Caroline. So we have your report on page 41 in our pack. So we'll leave you to give us an overview. Thank you very much. You need to turn your microphone on, but when you finish speaking, you turn it off.
Thank you. Okay, so thank you very much for having us today. Kirsten is here to deal with part of the report, and I'll deal with the improvement elements of it. So you've asked us to come and talk about our CQC report and the improvement around the services we're providing in Berkshire West, the hospital relocation, and then a little bit about collaboration, which has been in the news recently. So I'm going to do the first and last, and Kirsten's going to do the middle piece. So just for context, CQC came to see us about 2 years ago now. And as a consequence of that, we received a report rating of requires improvement and were put into the NHS Recovery Support Programme. We remain in the Recovery Support Programme at this point, although we are on a reduced level of scrutiny, because we have managed to improve certain areas, and I'll come to that in a bit. So as a consequence of that improvement programme, we've made significant changes over the last couple of years, particularly in senior leadership, and we are due to complete the appointment of new executive directors in April, and that will then enable us to reshape the executive team to deliver new leadership. At the same time, we've done a significant amount of modernisation of our governance processes by learning from others and understanding what best practice would look like, particularly around improving flow of information and using data to help drive our strategic and operational improvements. At the same time, we've undertaken a serious amount of work on our culture. So the report recognised a disconnect between our stated values and our behaviours. And so we've been doing a significant amount of work in that area. So particularly looking at things like sexual safety, freedom to speak up, and what we are calling a people promise, which is around how we are overall treating our staff. In terms of operational performance, our requirement has been to achieve our CAP 2 objectives within our means. That's been a significant transformation of services. And when Kirsten speaks, you will note that we're not achieving the 18-minute, which is the national CAP 2 standard. But we have in recent months been achieving the what's the right word? Relaxed target. I'm not sure relaxed because it's hard for us to get to, but the 30-minute target that National is expecting this year. That's being delivered through a significant transformation of services, particularly around telephone triage and how 999 and 111 are working together alongside changes on our on-road approach. In terms of patient safety, 3 areas that we were focusing on, and this is the area we've made most progress in. Safeguarding has been a significant priority for us, and we've done some significant improvements in our approach to safeguarding. We have been working quite closely, certainly in Hampshire, with peers to ensure that we're peer reviewing what we are doing. We've also done a significant amount of training in the Mental Capacity Act and ensuring that we're appropriately applying the law in that respect. And we've also implemented the new patient safety framework, which is a learning framework. So we learn from patient safety incidents and ensure that they don't happen again. So that's the PSURF framework, for those of you familiar with the jargon. Next steps, our focus for the next year is on performance improvement and transformation, on embedding the culture review, and on further improving governance. As I said, we're delivering much better performance, largely associated with reduced handover times for hospital. And one of the interesting things about this is we're noticing a virtuous circle. So if we get to patients quickly, patients have deteriorated less. We're able to do more with them at home and leave them at home, which is in turn leading to less conveyance to hospital. So there's something really important about that speed of response in actually improving the care that and the choices we're able to give to our patients. Looking to the future, we're looking this year to improve our use of community pathways. So, for instance, on what's known as hear and treat and see and treat. So it's where either we don't send an ambulance out because we triage a patient, or we send an ambulance out and then we leave them at home because we've been able to refer them, for instance, to urgent community services or into other pathways, so they don't need to go to hospital. We know hospital is not necessarily the right place for a lot of these patients. So we're doing lots of work on how we can change the balance of our activity more into that triage or home first approach. We're also doing a lot of work to improve our vehicles, and we're going to be increasing the number of paramedics that we have available to us. So that's all about getting to the patient quickly and being able to maintain that virtuous circle. So that's what I wanted to say about the first part of the report. I wanted to bring in Kirsten to talk about the specifics for West Berkshire.
Yeah, good afternoon, everybody. Thank you for the opportunity to talk to you today. As Caroline rightly said, I'm Kirsten Willis-Druitt, and I'm the Assistant Director of Operations for the Thames Valley.
Caroline to turn up. Thank you.
Could you hear that okay?
That carry on. Sorry. So you've got the microphone. We don't want any microphones on in the room while you're talking. So I was just making sure Caroline's was off. So sorry to interrupt. Sure. Please carry on, Kirsten.
That's fine. Did you hear my introduction or not?
We can hear you fine. Please carry on.
You can. Perfect. Okay, so obviously talking about the data, and you've received a paper ahead of time, which I hope everyone's had the opportunity to have a read through. So I work with the frontline operations, which is obviously providing the emergency care to the patients within the Berkshire West area and, like I say, across the Thames Valley. So if you look at the data, there's a data set that we've submitted there for January 2025. We take a little time to get the data set out with regards to February, so it's only up to January. What that's showing is the category 1, 2, 3, 4 and 5. So essentially category 1 is your immediately life-threatening calls, so those people that are unconscious, fitting or in cardiac arrest is that sort of thing. And we have a target time of 7 minutes to achieve that from the time of which the call that hits the switchboard. In other words, when you make the 999 call through to the minute that we have an basically a resource. Now that resource could be anything. It could be a community responder, it could be a paramedic on an ambulance, it could be a paramedic in a car. So category 1 calls, as you can see, for Berkshire West, our mean average is at 8 minutes and 28 seconds and accounts for 10% of our calls. But I'd like to just draw to attention, it's only slightly behind the mean average for the rest of the UK, for England. Which is at 8 minutes and 16 seconds. So we're not far behind. And for the 90th percentile, as we get to 90% of our calls that we received is at 16 minutes and 9 seconds. So we're doing really reasonably well. Category 2 is a success story. So 24 minutes. So Caroline referenced it's what's called a modified score. So essentially the government post-COVID, the actual target time for a category 2 call, which is people that are having perhaps strokes or breathing difficulties or heart attacks, but are still conscious. That's a category 2 call. And they essentially changed the parameters post-COVID, where we used to have a response time of 18 minutes. We currently, and this is for the whole of the UK, has a response time target of 30 minutes. So we are well within that framework at the moment. So for Berkshire West, we're at 24 minutes and 40 against a 30-minute target. We average much better timings against the England average, which is at 35 minutes and 40. So you can see we are doing much better in that situation. And I can also tell you that for January, we were the highest performing ambulance trust from the 11 UK providers of ambulance services to the NHS. So we are doing reasonably well very well for our category 2 response times, which is great to hear, and all part of our recovery programme. Category 3s and category 4s, I'll kind of bundle those together. So they are the sorts of patients that perhaps you've had a fall at home or have become unwell, maybe have an underlying waterworks infection or perhaps back pain, that sort of thing. So lower category calls that don't require us to get there in a sort of blue lights and sirens approach. So we are arriving on scene in 1 hour and 30 minutes. And that's against a 2-hour target. And against England, we are much better. So we're doing about 25 minutes better than the national average in England. So all in all, good news. Category 5 is just referencing hear and treat calls where we've not sent a response, which again counts for about 10% of our call workload. So the one that we really need to focus in on is category 1 and category 2s, which we are doing well for, and particularly well in your area. As 111 provider as well, so obviously that's a very high usage of service. And as you can see from the data again, from October through to December, these numbers, it's been increasing quite considerably, which is what we would expect to see across the winter months. And January went up again. So it's not unsurprising that happens. Of course, with those increasing volumes of calls, what we're seeing, to go up 13,000 across 2 months, of course, performance is going to be impacted with regards to the ability for us to answer calls. And we do, unfortunately, find ourselves sometimes with a stack, as we would call it, so people waiting to hear for us to answer. But that is a 111 service rather than a 999 service. So, slow time of how you can access primary care. Or other community providers that might be required. You've got some other data sets in there, which is just looking at outcomes from the 111 service. So the 111 has access to many different pathways that they can direct patients to. That does include being told to go directly to a healthcare facility, whether that be primary care or whether that be through to an acute trust, such as an emergency department or a minor injuries unit. It also could be that they get directed through to the 999 service and we go out. And that's what the second pie chart is showing, that actually that percentage. So the aim is to do less than 10% referrals through to the 999 service from the 111 service. And of those less than 10%, which is what it's showing, about half of them do require our input from a frontline ops perspective in the 999 and will require us to either treat and convey or treat on scene and perhaps discharge at home or to a community service. So hopefully that helps you to understand how we categorise those. Small percentage gets picked up of category 1 calls from the 111 service, but they are able to triage that through. Most of them sit into the category 3 or category 4 pathway. Next thing I want to talk about is the hospital handover times, which is something that comes into the media quite regularly. You have seen, queues of ambulances outside hospitals waiting to be admitted into the departments. That's a piece of work we've been doing a lot with our community providers. So 2 primary feeds for your area are Rawbarks, and we also go out of area to Great Western, sometimes down to Basingstoke as well, it just depends. But primarily it should be Rawbarks that we would come back into. So at Rawbarks and across all of the acute trusts that we have within the South Central Ambulance Service operating footprint, we have what's called, has been introduced as something called Release to Respond. So it's Release to Respond 45. So if we're getting to 30 minutes and we think we're going to start triggering, we start moving a team leader down to the emergency department to become a liaison with the department. And the minute that we hit 45 minutes that we've been waiting to get into the department, so if we've been queuing, whether that be on the back of an ambulance outside or whether it's within the department itself, we provide a notification to the senior staff within the emergency department and within the hospital to notify them that there is a requirement for them to accept our patients, because they are not our patients at that point. Once they've arrived at the hospital, they are theirs, and they have to find space to support them so that we can be released to go and respond to other patients that have perhaps of a greater need in the community. So that's a new thing that's come on board in recent, just before we went into winter pressure, so just before Christmas. And that has been working quite well, actually. We haven't had to implement it too much, which is reassuring. I think they absorbed the challenges, which has been really helpful. I'm going to pass back to Caroline now, I think.
Kirsten, did you want to talk about the Rawbarks hospital programme?
I don't know a lot about it, if I'm quite honest with you, so probably not, but I can if you want me to.
You probably know more than I do about this one.
The only thing that I'm aware of is that we are at a position where the hospital is essentially landlocked now, which it has been for a long time. There is very little scope for development and very little scope for expanding the emergency department, which is what's definitely needed. So the review is that they're now looking to, they've submitted a proposal, I believe, under the government's scheme to look at the new hospital programme. But like I said, I'm not close enough to the detail of that, and obviously that would be Rawbarks Foundation Trust that would probably need to talk to you in more detail with regards to that. But we certainly are collaborating as far as, they've come to us and spoken to us about what our needs would be and what that might look like. So we obviously will be engaged with them. But it's looking at, I think this is a wave 3 for construction. So I think it's quite a delay. So we've got a significant issue that is on the horizon at the moment with regards to the amount of delays that we have.
Maybe you're going to ask what I was going to mention. Go on, you go first. Go on.
I'll go first. It does actually say on our report on page 45 at 4 that you're actually meant to be feeding directly into the new hospital relocation plans. Is that something which has sort of arrived with you, as it were, or what is actually happening? You're aware?
I'm certainly aware of it. It's just not my area, so that will be my exec director, and he hasn't provided me with an update with regards to that. So I do apologise. If you do need to get an update, then that's fine. But we are aware of it. But I think it's very early days with regards to that collaboration. But we have extremely strong working partnerships with the RBFMT, so I don't have any concerns that we won't be fully engaged with that once it gets fully running.
It's only because it said actively, it says in the report, actively engaged, but I'm sure that at different levels it probably is.
Yeah, I was just going to obviously just observe that this, what do you call it? The release response.
Release to respond.
That release to respond. That sounds
Yeah.
That's the need to do that. Obviously, is once we had the new hospital and you had a bigger emergency department, hopefully that would not be quite so necessary. So you find yourself in this position because of the circumstances of the hospital there, or is it personnel? Yes, you're nodding your head.
Yeah. Yeah.
So obviously we're now at least 10 years on before we are possibly looking at this proposed new hospital. So that's quite alarming from your point of view, isn't it? So what you're facing there is doing something you don't particularly want to do, this release respond.
We've had to enact it across the entire organisation, you know, which is obviously something we've had to do. It's not ideal in any way, shape or form. We would love to have vehicles available to respond, but when we are, you know, we could be anywhere between 5 and 15, even 20 plus ambulances sometimes outside acute trusts waiting to go. When you think about it, I think people's mindset you'd think we have an infinite number of ambulances available. We don't, you know, that's not the case at all. Our rosters will support on average 25 at peak that are deployable in the Berkshire West area. So, you know, it's, you know, on a day shift, you know, and that drops down to about 15 overnight. Now, if 12, 14 are stuck outside a hospital for 45 minutes potentially, then obviously that's not a viable proposition, which is why we've had to implement it. But, you know, the Royal Berks is not unique in its delivery of that at all. You know, this is across pretty much all acute trusts. There's very few that are unaffected by that now.
Yeah. I mean, I was going to comment. I mean, your report, I think my colleagues would agree that it looks as though you've made immense improvements from, I mean, I don't know that any of us were aware there was a problem, actually, probably, but we've been fortunate enough not to, I shouldn't say this, not to have to use the ambulance service, touch everything. But the report shows how much work you put in to actually improve. And it's really, really impressive. The fact that, as you said, as Caroline said, or maybe it was yourself, that you're now the fastest responding ambulance service in the country. I think in the county, sorry, or maybe in the country. Yes, in the country. So I think that is really, really something to be very proud of. And I was also very impressed by one of the first things that you reported on in the report was looking at the work stream and culture and well-being of your staff. And I thought that was very impressive that you actually paid attention to that, because that's not always the case in other aspects of the health service. That you've got a caring community, they've got to do the caring, but nobody really cares for them. So, you know, it's actually, and having previously worked for the health service, I'm speaking from experience, so it was really good to see that this was something you gave as a priority, because if you don't care for your workforce, how can they do the job? So I was really impressed by that. Do you want to comment on that?
I wanted to say there's
no, thank you. Sorry, Caroline, you go ahead.
I think there's some really good evidence that having an engaged workforce actually improves performance. So while, yes, we are looking after our staff, we also have one eye to how are we using our staff to best effect, and how do we make sure that as a resource, they are most effective in what we're doing. So we're trying to go on the evidence of what's supposed to make an improvement, and that's what's driving us at the moment. We're trying to look at evidence-based ways of improving.
Thank you. Thank you very much for that. Councillor Langford?
Thank you, Chair. Yes, your record is impressive, and congratulations. Do you feel impeded at all by the stock of ambulances you have, their readiness to respond, or are they in the garage being fixed? And are they of a suitable vintage now to assist you, or are you working against this problem? And how would you like to see that fixed if it's the case?
There's a lot of questions there. Yes, fleet is a huge issue for us. I say issue, it's a huge part of our deployment. Of course it is. We're a mobile workforce, so we have to have vehicles that are serviceable. We have a couple of challenges at the moment. So firstly, there is a national re-procurement programme of ambulance. So we can only draw from 2 different styles of ambulance. So you think we would be able to go and buy, you know, a plethora of different vehicles. We can't. The government mandate that we can only have 2 different types. So that's around the different makes. So at the moment we have Fiats, which are what we would classify as van conversions. So the more sort of streamlined versions as opposed to the big boxes that you will sometimes see out and about still. Our procurement programme is done on a 5-year basis. So it used to be 7, it's been reduced down to 5 years. So every ambulance should be replaced every 5 years. Because of the fact that there are only 2 products that nationally we can go to, as all other ambulance trusts can do, that makes it a big challenge because trying to get those vehicles. There is one other company that's being allowed to come online at the moment, which hopefully we will be able to access, and we are actively looking at that at the moment. Currently, we've got 70 new ambulances coming into the trust at the moment, 25 of which have arrived in the country because they're not built in the UK, they arrive in the country. So we've got 25. So it's a fairly drawn out process to get that, but of course it's an ongoing process. So as you bring 25 in, there'll be 25 that will potentially be decommissioned, and only a few that have to be held on to if they're having fleet issues. The second issue that we have currently ongoing at the moment is we only have 2 workshops. We have one that's based down near Southampton, a place called Nursling, and we have a second one that's based at Didcot at Milton Park. And our fleet is outgrowing the workshop space. So we have to outsource some repairs, which is obviously more costly, and we want to have it in-house. So currently what we're doing at the moment is trying to procure a 3rd workshop location. And these are not your sort of standard garages. These are very large, for, as you can imagine, what they have to deal with in the fleet implications. We do have a new fleet operator. So he's one of our assistant directors, director of fleet. And he actually has a fleet operator license, which is a slight change to what we've done historically. But he's been with us for probably about getting on for 2 years now. And that's really been a big positive because he recognises the challenges that we have and has different ways of working. And that's been really good. But we have, during the winter, we have had some quite significant fleet challenges, which we are monitoring and we try to deliver on as best we can. Because it's not ideal to not have an ambulance available to respond on. But you can imagine, you know, we get so many challenges around, you know, tyres, vehicles, and they're completely different, serviced completely differently to a normal road vehicle would be. So we have to have a safety inspection every 6 weeks. So every frontline vehicle that's in any form of response has to go through our workshops every 6 weeks, which is a massive, massive undertaking. We don't have the luxury of MOTs, you know, you don't have to have one until they're 3 years old. We have to have them from, you know, day dot essentially. So there's lots of different challenges that we have to have, which means that we have to sort of work wisely, I suppose. But we've come through a difficult winter, I would say, this year. It's probably been one of our most difficult with regards to our fleet profile, but it is getting much better now.
Thank you very much. Councillor Stevenson?
Yes, Chair, I've got 3 separate questions, if I may. Can I do them one at a time? I don't know who would like to answer. In one paragraph, I read that the non-emergency patient transport services were carried on by you up to the end of March. And then from the 1st of April, there's going to be a new provider. And I think it's Bob ICB that's arranged this. Do we know who these new providers are, please?
Yeah, it's a company called EMED, EMED. And yeah, the ICB have obviously been going through their procurement. And yeah, we were very sadly, we lost the contract and it's been contracted to a company called EMED, and they take over the contract from the 1st of April from us.
And have we any of us the faintest idea who these people are and why they've been given this contract?
I wouldn't like to talk on behalf of the ICB because obviously it was a competitive contracting process. I can't see Caroline if Caroline's trying to indicate, so I do apologise if she wants to come in. It might be she wants to come in on that one.
Yeah, so just EMED is the largest provider of non-emergency patient transport in England now. So they have been picking up contracts across the country for a number of years. So they've got a track record. We're very disappointed to have lost the contract, but we've been working really closely with EMED in terms of transferring the staff and the resources to make sure that the service is up and running from the 1st of April, so that patients are not going to be suffering or unable to get the transport they need from the 1st of April. Yeah, but they are a well-known company.
Thank you for that. Quite interesting, Chair. My next one is, please, I read in 2.3.2 that your ambulance service is increasingly aligning operational leadership with county boundaries. And then later on in 5.2 under transformation, that you're going to work towards the creation of a group model. And the bit that worries me is the new model will include 6 ICBs and be huge. So wouldn't the scale of such an organisation mean that local accountability is lost?
Do you want me to pick that up? So I think our learning from being SCAS and being, how many ICBs it is, I lose count, 1, 2, 3, 4 ICBs, is that unless we pay particular focus to the locality, exactly what you have said has happened. So we lose the relationship. So the reason for going to the county boundaries is to make sure that we have built into our infrastructure the local accountability and the local relationships. That said, their SCAS, bizarrely, is in NHS terms a very small organisation. So although we're geographically huge, from a turnover perspective, we're pretty little. So that means our productivity and efficiency challenge is quite big. So the benefit of thinking about working on a different basis, and the reason we're talking about group models is because we feel that that there are synergies with, particularly with CCAM, Southeast Coast. So they're Kent, Surrey, Sussex. Is that we're fairly similar in terms of geography and preoccupations, and that there are things that we can do together that make a lot of sense. One of the things we think we can do together is to improve, it's not for us to do, but for improve the commissioning of our services. So there's big discrepancies in the way that ambulance services are commissioned and the level to which they're funded. We think that there are opportunities in coming together to be a more powerful voice in terms of the our funding and our ability to negotiate in this in the NHS world that we now find ourselves in. So the strategy is big where it needs to be big, local where it needs to be local, and we're just going to have to figure out the sort of in-between stuff. And I think that's what we've all been grappling with, how to make that work for quite some time. But we will continue to grapple.
I think that's quite cheering to hear your approach. Thank you. Can I ask the last bit? Thank you. The other one for me is always about AI and ICT. You've said you're going to move into bringing AI into the emergency operations centres. And the last sentence says, without excluding individuals who struggle to use technology. Now, I mentioned this every meeting I go to, and we went, the one that the chair and I went to, we heard that within the NHS, there's always going to be, that's the whole service, 5% of residents who will never access and use technology. How are you, therefore, going to allow for those people?
So when we're talking about using AI in our call centres, it's using AI to support our call handlers. So we're looking at 2 projects next year. One is around something called natural language processing. I don't know whether people have come across this, but the example would be if you phone 111 in London and you mention when you're asked what's the nature of your call, you mention you have an eye problem or you have a dental problem, you bypass the triage and you would put straight into a conversation with a dental provider or with a call handler, because they've done some analysis that shows if you phone up with an eye problem, there's no point in going through the triage. You will end up with them. So we might as well bypass it and move on. So what SCAS is starting to think about is, well, how can we take the learning from that? It streamlines the process. It's better for patients. It's better for us. It saves us time. At the same time, we can also collect demographic data through this process, which can automatically then populate the system. So instead of the call handler first saying, what's your name? How old are you? Where are you? All those sorts of things. You can be asked all of that initially. And by the time you get to the call handler, you're being asked about what your problem is, not who you are. So that's one of the first things that we're looking at. One of the second things we want to look at is how can we use AI to support the training of our call handlers. So one of the things that we hear is that when you go from the training environment to the live environment, it's a bit of a shock, because the pace, the complexity, working alone is more stressful than in the training environment. So we're looking at how we can use AI to make the training environment more similar to the live environment, so we're able to transition people more effectively. And we believe by doing that, we'll lose less people because they'll be more prepared for that environment, and we will improve our training. So that's just two examples of where we're going. But we're not asking people to do something different than what
deal with computers all the time.
Really interesting. Thank you. Councillor Carter.
Yes, it is. Just back on the 6 ICB. So there aren't 6 at the minute then, is that right? Because I read it as the were 6, but you're on the section 5.2, this point about the collaboration with what you're calling CCAM, which is a French television system, by the way. Is the 6 integrated care boards now or not? You said there weren't, I think. Sorry.
There's 4 in SCAS for South Central, and there's 2 in South East Coast.
Oh, so it's existing
So
6.
it's
Yeah.
six together.
And I was going to ask you, but you covered it. What kind of areas are you looking? Because you said a lot more than is in the report. The report doesn't really go into any detail at all. It says about strategic lead and roadmap and all the rest of it. Is, for example, the IT work you're looking at, would that be something that you'd share? Presumably it is something you'd look to work with the other folks on, but are there any other areas that you want to mention?
Yes, so we're one of the things that we think we can do really usefully together is implement what's known as a quality improvement methodology and a QI approach. So the idea being that we do a lot of transformational work, which is big ticket programs, but how about that bottom up? People notice a problem and they fix it for themselves. Culture, so it's part of our culture work. So South East Coast have a fantastic QI program already in place. And so what we're thinking is, why reinvent the wheel? Why don't we piggyback on the back of what they're doing and bring that into South Central? And we get the benefit of everything that they've already learned, and we can just go from there. The other thing that we're doing is looking at, what do we do, what do you do, compare and contrast, and why? Because we think there's opportunities to do things differently when we understand how different people do things. And in some cases, we're better, and in some cases, they're better. So how do you bring the collective benefit together? And that starts to drive out the efficiency.
I think Kirsten wants to comment. Shall we see what she wants to say? Kirsten?
Thank you. I was just going to pick up on taking aside from the ICBs, the big change that we're making. So currently we have 7 what we call nodes, so operating areas, I suppose you'd refer to it as, and we are reducing that to 6, so which makes much more sense. So the biggest changes for the Berkshire area. So rather than it being Berkshire West and Berkshire East is how we are at the moment, we're going to go back to being the whole of Berkshire together. So Wexham, Slough, Slough, Maidenhead and Windsor will come back into the Berkshire area as a whole Berkshire for us. And then the sort of North Bucks part of it, the Bucks or East Bucks, should I say, which currently comes into the 7th area, will get absorbed into Milton Keynes. So it will go upwards. Half of it will go upwards, and half of it will come across into Berkshire as the 7th area that we had. We were going to go into 6 areas, which makes it much more efficient for us as well, because we'll have 3 areas in the north, Oxfordshire, Buckingham and Berkshire, and then 3 areas in the south, which will be obviously the North Hampshire, Portsmouth and Southampton systems for us. So that's also the 6 operating areas that are reducing from 7 down to 6 for us.
Probably just a quick follow-up, and this is a bit of a, I was just thinking with the, it's not a help desk, obviously, the emergency services, but when you were saying about the starting point, which it sounds a bit like you might be talking to a robot at some point, which I'm sure is fine, who takes your details. Does it, I hope, then fish up all your background information and say, actually, this guy's had a heart attack 3 months ago and that kind of thing? Is that how it works? A bit like in my head, I'm thinking of help desk for mobile phones. You ring the help desk and in theory, they know that you're on a contract and you've had a fault before, that kind of thing. Does it work like that?
I can't, that's the idea. I can't tell you exactly what order we're going to be doing things in, because we're piloting various different aspects, and we're hoping to pilot rapidly because we think there's huge benefit to be got out of this. But the first step is the taking the detail. Do we efficiently take the details? And once we've done that, we can then move on how we're linking things up. But the intention is to remove steps from the process where that can be done safely. But what we've got to be very careful about is, for instance, safeguarding and patient identifiable data, because we wouldn't want, for instance, somebody to be able to get through to someone and pretend to be somebody else without some checks and balances along the way.
Right.
Thank you very much. I was going to, you probably touched on this already with answering Councillor Stevenson's question. Page 41, in the last paragraph, you say you meet monthly with NHS England and Hampshire and Isle of Wight Integrated Care Board, who are your lead commissioners, to review progress, and you have quarterly keep in touch meetings with the Care Quality Commission. How do you communicate with Bob ICB?
We have a strategic commissioning forum, which is organised by Hampshire and Isle of Wight, includes Bob, Frimley and Milton Keynes. So we meet once a month with all of those commissioners in a room to discuss at the moment it's things like contracts and planning and things like that. Later on it might be about performance or transformation activities or national strategies or priorities or something like that. But we meet monthly with the Bob commissioners. We also, where there are specific programmes of work underway, we'll meet one-to-one with those Bob programmes of work as well.
That's good. And the other little question I was going to ask, and I think we hear a lot about inappropriate calls to the ambulance services, but looking at your little circles, the stats on page 45, it doesn't come up that there's much. Maybe is that 1%? Would that be the inappropriate calls? There's nothing there that says these people shouldn't have called us. I suppose you're just being very magnanimous, you know, that every call could have some sort of need. But we do hear of lots of inappropriate calls. Is that a problem or not?
We still do get inappropriate calls. I think we would prefer not to call them inappropriate calls. We just prefer that somebody's looking for some help and they come to the wrong place. We can deal with those these days through hear and treat. So we're able to, if they don't need an ambulance and if they don't need other care, we can close that on the phone, or we can direct them to the appropriate place.
Yes, we've got lots of stats about that, haven't we? And the other thing I was going to say is that on page 44, you're waiting for the reassessment of your rating. And it seems to be taking quite some time. Can we help in any way there? Can we sort of write in support of you and say, we're extremely impressed, would you please hurry up? Is there anything we can do?
So we are waiting for a reassessment. I'm not sure we would want it quite now. The reason being is that we still feel, although we've done an amazing amount of work, and we have, I think there is still more work to do. And part of what needs to settle is the senior leadership team need to settle, be in post and settle. Because at the moment, if the CQC were to visit today, for instance, there would be people who are still on interims or long-term long-term interims. It would be better for us for I want to say investigation, it's not a visit. It would be better for them to visit when we've got that stable team in place and we've had a fair run at getting those people into the right place. But the CQC will visit when the CQC will visit. They have recently visited. They visited East of England, and we know that although they paused their visits while they were re-looking at the framework they were investigating under, that we could be due any time.
Okay, right. Well, that's really, really interesting report, and I think we've all found it very informative. Members got any more questions? Oh, Councillor Langford.
Sorry, Chair. In my time in work, when we improved a company and their customer care, we found that people didn't realise that we'd improved it unless we told them. So the old perception persisted. So have you got any plans for telling your public that you've improved? And if so, how?
So we do have a communications plan. One of the things, however, that we are cautious about at the moment is we want to tell people we've improved when we know we have sustainably improved. And to know we have sustainably improved, we need a series of data that shows that. And so we are hesitating from singing from the rafters that we've done a lot better until we know, or we're reasonably comfortable, that we've got the proper evidence for that.
Excellent. Well, thank you again. Thank you very much for your report, both yourself, Caroline and Kirsten. Thank you for joining us, and we'll look out for that publicity about how well you've done. Thank you very much. Thank you.
Thank you.
Have we got Jo England? Is she coming, or she's going to come on there? Okay. Well, members, the next item we've got is Jo England, Service Lead in Adult Social. Oh, there she is. Hello. I'm just waiting in the background. Jo is Service Lead on Adult Social Care, and she's providing a brief overview of the Social Care Inquest report, which you'll see on page 49. Thank you, Jo.
Okay, thank you, Chair. So this is a very brief report. It's annual report following on from last year's report. So the brief background was in May 2022, we'd seen an increase in cases where West Berkshire Council had been approached by the Berkshire Coroner's Office for information and or been identified as party to an inquest. So since then, we have set up a inquest review panel that meets monthly. Currently, I'm chairing that, and we look at any inquest requests that we've had, or any requests for information, sorry, that we've had from the coroner, and also we keep on our radar any possible requests for information from the coroner. So occasionally there will be an incident that we may think may or may not go to coroner's inquest, so we also kind of keep that on our radar, so we're cited on it. We've seen a levelling off of requests for information since that spike in 2022. And as you will receive from the report in 5.4, we've had 3 cases in the last year, and the kind of brief details around those cases.
Right, thank you. I was going to ask about the third of those cases in 5.4. It says one case was a care leaver and I had recently transitioned to adult social care. So a multi-agency rapid review meeting has been called. So has that meeting happened? I mean, it sounds as though that could be quite an important, I don't know, incident, as it were. Is there any
Yeah.
learning that's been made of that? Because it's a key situation, isn't it, that transitioning? And I wonder.
Yeah. So not as yet. And sadly, this young individual passed away literally just as I was compiling the report. And because they are a care leaver, children's services have a responsibility up until the age of 25. So although he was 18 and had transitioned to adults, because he's a care leaver, children's needed to call this multi-agency rapid review meeting, which they've done, and they're just waiting for the feedback and learning from that meeting.
But my thought was, because of this difficult transitioning phase, was there something, if he wasn't transitioning, he or she, would there have been some more support than there was? Has that got anything to do with it? No.
No.
All shaking his head.
No. It's we have to call the multi-agency rapid review meeting because they were a care leaver, not because of the circumstances of what happened.
Okay, thank you very much. That clarifies that, and we've got Heather and Paul here, so which is very good. They're nodding away. Okay. Have members got any questions on this report? No. Okay. Well, thank you very much, Joe, for your report. And we'll note it. And thank you for your time, and thank you for waiting there.
That's fine.
Thank you very much.
Okay. Thank you.
Members, now we have the Health Watch update. So we have Fiona, who again has been waiting extremely patiently since the start of the meeting. And Fiona is giving us a verbal report on Health Watch's activities. Thank you, Fiona.
Hello there. Currently can you hear me okay? Just wanted to know, yes.
We can hear you. You're a little bit faint, but we can hear you.
All right, thank you. Yeah, currently Health Watch are quite busy. We are looking at our new work plan for the upcoming year. We are closing down some of our old projects from the previous year, and we'll be pushing reports out very soon with those. We have been involved in the Women's Health Hub issue that you may or may know about. And that is an ongoing project for us currently as well. So we're quite busy, and we have lots and lots of work coming up as well, which is really good. So yeah, I will provide a full report at the next meeting, if that is okay.
Yes, that would be good. What did you mention, Fiona? A health hub, did you say?
Yeah, there was Women's Health Hub issue that has been happening recently over the last few months. It was an initiative come from the NHS in 2023. Some money was given to put new women's health hubs into the areas that didn't have any, and unfortunately that didn't happen for us in West Berkshire. So we've been investigating into that issue currently.
Thank you. Paul would like to comment on that.
Thanks. Yes, we're saying it's a shame Matt's just left. His was one of the names on the letter that went to the Integrated Care Board to express concern about the fact that there was this gap in provision in West Berkshire. It was raised very briefly at the Health and Wellbeing Board whenever it was last week. Yes. And so we've had a response from the Integrated Care Board, but there will be a response back because the response from the ICB was a bit of a kind of a,
to do with, sorry, I didn't hear very clearly. This is to do with women's health?
Yeah, essentially there is a lesser service in West Berkshire than there is in Buckinghamshire and Oxfordshire. Yeah.
This is what, around pregnancy and those issues, or gynecology?
Currently there has been some money was provided from the NHS, and it basically was utilised elsewhere. So we, Healthwatch, spoke to ICB and asked for an update on what was going on, and a small service for women's health was provided just as a pilot for 6 months, which is coming to an end currently. And there is no further provision from ICB going to be made, which we are contesting. We received an FOI from the ICB last week, which wasn't very satisfactory, I'm afraid. And we are still currently working towards this going forward. So it's a little bit, it's still an ongoing issue.
Well, thank you for that. Well, we look forward to hearing more probably at the next meeting, when, as you said, Fiona, we'll have a written report, which maybe will give us a bit more information.
Yes, it's still, we're still having, currently there are lots of meetings going on, so I can't give you a definitive response currently, unfortunately, but you know, as I say, there are things, the ball is rolling, and Paul is well aware, obviously, and Matt is well aware, so there's lots of things happening around it. But yes, I just wanted to know from a Healthwatch perspective, we raised this issue with the ICB because it had gone quiet, and that's why this is all happening now. So I will be able to give you a much further and much more clearer update at the next scrutiny meeting. So apologies for not being a little bit vague today. I do apologise for that, but as I say, it's literally still going on.
Okay, well, thank you for that. We know that you're a small staff, but we look forward to hearing more at the next meeting. Thank you for being there, and thank you for waiting. Thank you. I assume members have got no questions for Fiona. No. Thank you very much, Fiona. Thank you. Bye for now. Right, members. Item 10 is update on our task group. As you know, we have a task group which is looking at children's mental health and emotional well-being. And Councillor Stevenson and Councillor Jeffrey from this group serve on that, along with 5 other members. And we've carried out 2 of the sessions so far, meeting with partners from health, education, the council and the voluntary sector. And they've been very useful and informative meetings. And we have 1 further session, which is scheduled for later this month. Following these, a report with recommendations will follow and be presented at a future Health Scrutiny Committee. Members got any questions or comments? No? Councillor Jeffrey?
Is one absolutely minor detail. If you look on the list, on the 23rd of September, 3 should be 4, 4 should be 5.
What are you referring to, Councillor Jeffrey? Sorry, which?
Sorry, on the health scrutiny work programme. If you look down against the references, it goes 1, 2, 3, 3, 4, 6, 7, 9, and it should actually be 1, 2, 3, 4, 5, 6, 7, 9, I believe.
We're actually not on the work programme yet. We're talking about
well,
yeah. All right, thank you for that, Councillor Jeffrey. Okay. Right, so the next item is item 11 is the work programme, and on page 59, and you can see that what's coming up in June. Following that, we don't have items listed, although there are things pending, but because it's the beginning of another sort of year, we're just sort of reassessing and looking at priorities, etc., to see which items we bring forward. Councillor Stevenson?
Yes, Chair, does Vicky automatically put on all of the things we've asked to reassess and revisit today? Will that go into our work programme?
Yes. So there'll initially be actions that are to add it to a work programme. So for instance, continuing healthcare was an action from the last Health Scrutiny Committee, and it will be on in June.
And dentistry?
Dentistry will be a 6-month as requested, so that will be September.
And the ambulance service perhaps coming back to us with updated figures? When do they reappear? Not for years?
That might be quite brief, because
It's up to what you request.
Well, we were very impressed by them, weren't we? But maybe maybe a short report, but I don't think we're as concerned about the service as say we are with dentistry.
No.
If we're looking at scrutiny, we can see how well they've done, although we did hear from Caroline that she thinks that more could be done. So I don't know. Would you like to see some more?
It did strike me when Councillor Langford asked about advertising their successes that we never even knew they were in trouble. And so perhaps best not to say they've succeeded in turning it around when no one knew they're in trouble anyway.
Well, possibly we didn't know. Oh.
I was just going to say, when the report landed, they did come and report to this group and to help hold their hands up and say, good Lord, this is much worse than we thought. But yeah, it was a little while ago. Yeah.
Right, okay. But there probably are people out there that did know there were problems. It's just that we were fortunate enough not to know, really. So, yes, so we would like to hear when the health process has been completed, I suppose, would we? So the Yeah.
Chairman, I think there is a perception amongst the public that the ambulance service is not as good as it ought to be, and it's luckily it appears to be an old perception. But when you've got old perceptions, you do need to correct them when you've improved. So I was very pleased with that. I have to say, I was very impressed with Caroline. And certainly, sorry, I didn't mean to be rude to her. No, she was also very impressive.
Paul.
So while we're talking about Care Quality Commission assessments, they came and looked at West Berkshire Council from an adult social care perspective and associated activities, and they came to us in February of last year. At some point, I would like to bring a report here that gives an update on what have we done since. So we were good, by the way, in case anyone's wondering. So it wasn't, there were no alarm bells, but I think bringing a report here about what have we done since that visit. A bit like you heard earlier, I don't know when they'll come again, but probably 2 to 3 year cycle is about sensible. So I think maybe September, December to bring so that this committee feels cited on how we're doing on the adult social care piece. Is that right?
That would be very useful. Yes, hopefully. Yes, Councillor Stevenson.
Sorry, there was just something way back in the minutes that I failed to raise. We did talk about the disputes policy that you're very keen on, Paul, but also we asked for clarification around joint training to address inconsistencies. And I put it, or it was in the report, it was advised that there's a new structure and dates for training were being confirmed. However, it's not certain whether the training would be joint due to the resource constraints. Was there an answer?
So I can say that the structure has changed. So, for example, when we confirm the disputes policy, those will all be considered at by a central hub across Bob, hopefully flattening out the discrepancies for Berkshire West. And I do know that, so as I was talking to ICB colleagues last week, and they were very keen that we make sure that we do send our people along to the training. I don't have all of the detail on exactly when is the training being delivered, but yes, there is training. It's been stood up, and it will be consistent across the Bob patch.
Thank you for that, Paul. So members, if anybody's got any further input or suggestions for items for further scrutiny, please let us know. And just to note that for any public that might hear this, there's a form on the website which allows people to nominate topics for Health Scrutiny Committee to consider. And if members think there's any ways we can get that message out to the public or get better publicity about health scrutiny and what we do, then obviously let us know whether we think there should be more items in the council's newsletter, anything that you think can actually spread the word about what we do. We did have a little bit of publicity a while back, but I think we need to keep telling the public that what we're here for and invite them to question us and bring things to us. Okay. Right. Well, thank you very much for that. If nobody's got any further questions or items, I think. Yeah, Councillor Carter.
Oh, it was only just a comment. I just looked up, can't find it now, but when we were talking to the dental chappie who then spoke up and said about what it was really like in the dental service, it's actually widely known that the health secretary has said that he thought the NHS dental was at death's door. And in fact, the Guardian a couple of weeks ago wrote an article which said exactly what the chap said. So I felt perhaps we should have perhaps been, in hindsight, slightly more mindful about the fact that we were saying that the dentists are all making a lot of money. It's quite clear that anyone running an NHS operation is not.
Thank you. That's a good point. Yes, they are a business and they have a lot of overheads, a bit like our GPs. So yeah, thank you. Thank you very much. Well, thank you, everybody. Thank you for your contributions and thank you for making this a very useful meeting. Thank you. Bye-bye.